right, my topic today is peripheral vascular intervention to facilitate trans-femoral TAVR, and I'll start out by saying whether or not you plan to have or be a peripheral interventionist or have that be a major part of your practice, I think it's imperative that whether you're a coronary interventionist or a structural interventionist, that you need to have at least some basic peripheral vascular skills, not only to facilitate access, but also to get yourself out of trouble, cause complications at one point or another with the peripheral vasculature will occur. My disclosures. So transfemoral TAVR is the most common access site for TAVR. The delivery systems are now 14 to 16 French. Transfemoral approach is associated with lower mortality and conversion rates to open surgical AVR as compared to non-transfemoral TAVR. Length of stay is shorter, recovery is quicker. And probably the major reason for failed transfemoral access includes small caliber and obstructive disease. Contraindications to non-femoral TAVR: hostile chest, bypass grafts, porcelain aorta, small tortuous axillary or subclavian approach vessels, anesthesia, intubation risk, LV aneurysms, etc. So we'll start out with a case report here. This is a 90-year-old female with critical AS, remarkably active. She still was driving, very mentally alert. Severe PID with claudication. She was only willing to consider a transfemoral TAVR. She was known to have multi-level PAD. You can see that even a subclavian approach would have been difficult because of severe tortuosity and calcification, and not to mention the fact that her transaortic would have been also a high risk because of the intense calcification or so-called porcelain aorta. So we started initially with micropuncture access. You can see in the left frame that there's a little hard to see on the screen here, but intense calcification, significant pressure drop across this area. So even for access to the closure device or the TAVR sheath itself required pre-dilatation. We used a chocolate balloon in this case. In the right panel, we were subsequently able to advance the vascular closure device, in this case a ProStar device, which has 4 sutures. Advanced up higher, again, you can see a very eccentric calcified lesion in the common iliac artery, which we then approached with balloon angioplasty. This allowed us to get our TAVR sheath up past that initial obstruction. And on the panel on the right, you can see that there's 2 high-grade aortic lesions, one kind of midway between the renals and the bifurcation, and one just under the renal arteries. So we ballooned and stented the more distal lesion. The more proximal lesion, we're a little concerned about stenting and snow-plowing plaque into the renal artery, so we did a gentle balloon inflation there, which allowed us to get past the second aortic lesion. We went ahead and did the pre-dilatation with a balloon and then deployed the valve. At this point, we were very happy. We thought, well, we managed to deal with the peripheral disease. It was almost Miller time. And then we removed the delivery sheath, tied the ProStar sutures, took a look from the other side, and realized that in spite of adequate anticoagulation and ACT over 300 and flow around the catheter, that we had developed obstruction. So we went ahead and did a very distal common femoral puncture and deployed a single covered stent, restoring normal flow. Post-procedure, the patient was awake very quickly, no further groin complications. She was out of bed the next day and home on the second post-procedural day. And in follow-up, she continues to do well. At our institution, we looked at 155 consecutive TAVR procedures where 16 patients had been referred to us or turned down for femoral TAVR because of what was called prohibitive aortic, iliac, and femoral anatomy identified by the pre-procedure CT. 13 of those 16 were managed to treat with PTA done at the same time as the TAVR. 2 were implanted trans-subclavian and 1 trans-apical. All 13 treated with PTA had successful transfemoral TAVR, and there was only major bleeding in 1 patient with no major sequelae after that, and 1 patient had the flow-limiting dissection, which you saw in the case example. So I think it's important to understand that whether you're doing coronary intervention or structural heart intervention, It's important to have the tool set on standby that you'll need to take care of your vascular complications. In conclusion, PAD is one of the few remaining barriers to transfemoral approach for most TAVR procedures. Peripheral vascular intervention can be safely carried out at the same setting as TAVR procedure in order to facilitate transfemoral access. Vascular complications remain a major potential complication of the transfemoral approach. Possessing a strong peripheral and interventional skill set not only allows the structural intervention to facilitate vascular access, but also to address any vascular complications that may occur without the need for urgent vascular surgery intervention. Thank you.